The following podcast is part of a certified educational activity titled At the Nexus of Sequential Care in Myeloma, Interprofessional and Patient Perspectives on GPRC5D-Directed Therapies. Access the entire activity and complete the post-test at peerview.com/WMD860. Downloadable slides and practice aids are also available.
Hello, I'm Donna Catamero, nurse practitioner from the Mount Sinai Health System in New York. Welcome to At the Nexus of Sequential Care in Myeloma, Interprofessional and Patient Perspectives of GPRC5D-Directed Therapies. Today, I'm pleased to be joined by my colleague, Dr. Josh Richter from the Tisch Cancer Institute. During today's program, we'll look at a team-based care in relapse refractory multiple myeloma with a focus on how we can collectively deliver effective therapy to our patients by targeting GPRC5D on myeloma cells. Throughout, we'll explore interprofessional and patient perspectives on this topic and provide insights from our own practice. We'll also make dosing and safety principles that we're discussing today available as downloads, as practice aids, so you might want to access these tools now. So let's begin. So during this presentation, we hope that you'll learn that GPRC5D is a unique target in myeloma that allows for flexible treatment planning. On-target, off-tumor side effects, including oral and dermatological toxicities, differentiate GPRC5D bispecifics from other T-cell engagers that require tailored management strategies. Collaborating with our healthcare team members can help ensure that patients receive adequate, safe, and appropriately dosed therapy with GPRC5D agents. The HealthTree Foundation is in partnership, and it provides tools and resources for patients, offers comprehensive personalized support through education, webinars, and podcasts, and has meaningful peer-to-peer, patient-to-patient connections. HealthTree also has Care Hub Registry, which supports patient researches by collecting patient information and providing visual tools for our patients. HealthTree Foundation supports patients by providing them education and resources right at their fingertips. Please use this QR code for more information. I'm going to hand over this presentation to my colleague, Dr. Richter.
Thank you so much. Really happy to be part of this educational program. And over the last decade, we've come extremely far in the development of new therapies, particularly in the realm of relapsed and refractory multiple myeloma. And really, when I think about relapsed myeloma, I like to think about the three great epochs of treatment. The first being classical chemotherapy with regimens like VAD, melphalan, cyclophosphamide, classical chemotherapy. The second epoch being the advent of novel immunotherapeutics, with drugs like the immunomodulatory agents, the proteasome inhibitors, and even the CD38-directed monoclonal antibodies. But in the last few years, we've really moved the needle with T-cell redirection therapy, and most notably with BCMA-directed therapies. This really came into the fray in 2021 with the approval of CAR T-cell therapy, and now we have two approved BCMA-targeted CAR T-cell therapies, ide-cel and cilta-cel. We've also had a number of bispecific antibodies that have been approved, including 3 bispecific antibodies that target BCMA, and an additional one that targets GPRC5D. And in 2025, we had the reappraisal of belantamab mafodotin, the BCMA-targeted antibody drug conjugate. And together with all of these new therapies, we're seeing some of the most amazing survival rates and outcomes for our patients that we've ever seen. However, when we think about the ongoing unmet need for our patients, the global unmet need still remains curative therapy for all. And most notably, when we're talking about patients in the relapse setting, we traditionally refer to triple-class refractory as being the major unmet need. We refer to triple-class refractory patients as patients refractory to an immunomodulatory agent like lenalidomide, a proteasome inhibitor like bortezomib, and a CD38 monoclonal antibody like daratumumab. However, now that we have patients patients receiving BCMA-based therapies even beyond triple-class refractory, our next big group are patients who progress beyond BCMA-based therapies. We can see some data here that's been presented by Dr. Kaja Weisel, looking at real-world evidence for what happens when patients do progress on anti-BCMA therapy. And we see overall response rates of less than 25%, with relatively limited progression-free and overall survival. So we continue to need options for patients in the setting of not only triple-class refractory, but also refractory to some of our newer therapies, including those targeting BCMA. What has been really exciting has been a novel target called GPRC5D. Now, GPRC5D is universally expressed in plasma cells, particularly malignant ones. They are not really expressed on other cells as much as some of the BCMA-based antigens are, especially when it comes to the hematologic components. So we don't see the same type of depth of immunoglobulins, as GPRC5D is not expressed on CD19 positive B cells. So hypogammaglobulinemia is not as common, though we will talk about some of the other on-target off-tumor expression of GPRC5D, which makes up part of its side effect profile. In addition, we recognize that expression of GPRC5D is independent of BCMA. So we may have patients who no longer express the BCMA antigen in a post-BCMA setting. However, they still will express the GPRC5D antigen and may be responsive to those type of therapies. Now, when it comes to bispecific antibodies, the GPRC5D targeting one is called talquetamab. Now, bispecific antibodies have two arms. One arm engages with the malignant cell. The other arm engages with CD3, which is located on our T cells. To me, this reminds me of the adage of Thunderdome. Remember the old movie Mad Max Thunderdome, where the motto was 2 men enter and 1 man leaves. So the concept here is that the bispecific antibody grabs onto the tumor cell with GPRC5D, grabs onto your own endogenous T cell with CD3, both cells enter, and only the T cell leaves as this drug activates T cells to attack the myeloma. Here we can see the 4 sentinel trials that led to the approvals of our currently approved bispecific antibodies: teclistamab, elranatamab, talquetamab, and linvoseltamab, with all except talquetamab targeting BCMA as a target antigen on the malignant plasma cells. Now, at the current time of this recording, these therapies are FDA approved for relapse refractory multiple myeloma for patients having at least 4 prior lines of therapy. And we can see the sentinel data coming out of the Majestic-1, Magnetism-3, Monumental-1, and Linker-MM1 studies. The current NCCN recommendations for utilization of bispecific antibodies is in late relapse. And in the world of myeloma, we refer to early relapse as 1 to 3 prior lines. Late relapse is 4 or more prior lines. And we can see here an updated list from the NCCN for patients who have had at least 4 prior therapies, including a CD38 monoclonal antibody, an immunomodulatory drug, and a proteasome inhibitor, that we do have the options of CAR T-cell based therapy. However, due to the fact that there may be some limitations on both appropriateness of patients and access to CAR T, we need to remember that bispecific antibodies can essentially be prescribed anywhere in any clinic, and we have a number of antibodies at our disposal. So there are a few thoughts about sequencing when it comes to both BCMA and GPRC5D as target antigens. When we consider patients who are rapidly progressing, we oftentimes consider a bispecific over a CAR T. For CAR Ts, for many years, we've referred to what's called the vein-to-vein time, which is the time in between the pheresis of the T cells and the reinfusion of the engineered T cells. However, we recognize that there's a prior process of patient identification, chemotherapy holding, apheresis identification date. So we now refer to the brain-to-vein time, which can be 2 to 3 months at a minimum. However, diseases don't have to read textbooks, and we sometimes have patients in clinic with rapidly progressive disease who cannot wait for this type of delay, in which case bispecific antibodies as off-the-shelf assets can be used at any time. In addition, we recognize that patients may ultimately go through a number of different T cell redirection therapies, and we can use these in sequence. In general, the data has shown that if you have one prior T cell redirection therapy, the next one is still likely to work, although on the whole, we see about a 10% declination in response rate with successive T cell redirection based therapies. But one option may be to switch up the antigen. Of note, because GPRC5D and BCMA are independently expressed on plasma cells, we see particularly efficacious results when utilizing GPRC5D based bispecifics such as talquetamab on patients who've progressed after either BCMA based bispecifics or BCMA based CAR T therapy. In addition, if we're ultimately planning on getting a patient to a CAR T, as CAR Ts at the moment are only approved that are BCMA targeting, a GPRC5D based bispecific allows us to debulk that patient, get them ready for apheresis and collection, and still proceed ultimately forward with a BCMA based CAR T without worrying about downregulation of the BCMA antigen. Now, one of the questions that has become absolutely key in the world of myeloma, particularly in the United States, well, is if one is good, is two better? So we've looked at a number of ways to combine both the BCMA and the GPRC5D antigen. The first was the redirect study, which has been published and presented by Yael Cohen, in which we combined teclistamab and talquetamab for patients, particularly those who had extramedullary disease. And we noted that there are extremely high response rates with an overall response rate of around 80% at the recommended phase 2 dose, with more than half of patients achieving a complete remission. In addition, in the US, this was specifically studied in patients with EMD only, with response rates of over 80%. More recently, Rakesh Popat presented the initial results of the J&J 5322 trispecific antibody. So here, instead of combining two bispecifics, it's a single molecule that targets CD3, GPRC5D, and BCMA. And at the recommended phase 2 dose, we saw a 100% response rate. So we're anxiously looking to the future of these different approaches towards combining GPRC5D and BCMA assets. And with this, Donna, I think I'll kick it back to you.
Okay, so let's talk about our case patient today. So Diane is a 69-year-old patient with relapse refractory myeloma. She has a pretty good performance status. Some of her other comorbidities is that she does have, I would say, mildly controlled type 2 diabetes with hypertension. She lives in a rural location, but she does have access to an oncology clinic. However, she does not have a caregiver. When we look at Diane's treatment history, she was initially treated with a quad therapy with daratumumab, bortezomib, lenalidomide, and dexamethasone. She's had several relapses and is currently on her fourth line of therapy with selinexor, bortezomib, and dexamethasone. Unfortunately, we do see a rising protein with Diane. In fact, she does have a new anemia with a new lytic lesion. So, Dr. Richter, what do you think the best choice for Diane is in this clinical picture?
So I think this is a rather tough case. And this is where I like to think of myeloma like a chess game, where it's not just important as far as what your next move is, but how does your next move impact the move after that and the move after that? So the first discussions, as the patient seems to have worsening myeloma, but not, oh my God, need to throw in the hospital today myeloma, is a CAR T going to be part of her ultimate approach? Because if it is, and we need to get control over disease now, I might start off with a GPRC5D based bispecific like talquetamab to then try to get her to a BCMA CAR T, which may be one option. If the patient does not want to go through the whole process involving a CAR T, I would typically start with a BCMA based bispecific and then move on to a GPRC5D based bispecific at the time of relapse, but absolutely open to if you do anything different.
I see that she doesn't have a consistent caregiver. Would this influence if I start a BCMA versus GPRC? Um, she might not have a caregiver now, but remember, we work with a larger team. We work with social work that maybe we can get a caregiver for her. So CAR-T will always be an option, I would think, for her. But I think, going to a GPRC5D based therapy is a good option for her. Um, so let's just say we did choose talquetamab for Diane. What are the safety considerations that you would discuss with her, Dr. Richter?
Sure. So, I think one of the terms that you started off the talk with, which is the uh, off-tumor on-target toxicity of GPRC5D. And this is something we need to let the patient know that they may want to expect happening. So we recognize that GPRC5D is not just expressed on malignant plasma cells, but on the squamous epithelium of the hands and feet. So patients can get a desquamating rash that to me reminds me of what we used to see a lot more with Xeloda. So patients need to be on the lookout for both skin changes as well as some of the nail changes. In addition, we recognize that GPRC5D is expressed on the oropharynx and salivary glands, so dysgeusia, xerostomia may come into play. In addition, we've noticed, and again, this is a little more common, it seems, with some of the GPRC5D CAR T assets, that because of the expression on the olivary nucleus near the cerebellum, that there may be some dizziness or ataxia that has been seen, although I think we've seen this a little bit less with drugs like talquetamab.
Right. And I think it's really important before initiating therapy with GPRC5D that we set expectations, and really educate on all those on target, off tumor side effects. And I think, these are what the side effect profile looks like. And this is how we want to manage these side effects through our supportive care. And I think, if we set those expectations prior to initiating therapy, we can keep patients on therapy. And we see that, talquetamab is a very effective drug and patients do well. So now let's talk about important safety considerations when starting patients on GPRC5D therapies. So we want to take a total team approach when caring for our myeloma patients. Um, and so this involves, I always say it takes a village. It's just not the nurse and the physician, it's a whole team. So, we involve the social worker, as I said, is very important. Um, the pharmacist, the nutritionist, and any other supportive care team members to get that patient through. So, the oncology nurse plays a central role in that patient education, monitoring symptoms, early recognition of toxicities, these on target off tumor, but also cytokine release syndrome and neurotoxicities. And as a nurse myself, I look at us as we're the frontline communicators. So we talk to the rest of the team. And then social works. I don't think I could live without my social worker. They help us address logistical barriers with our patients, transportation issues, and even that, support system for patients. And then our pharmacists, they ensure appropriate medication management. They monitor for interactions. They support dosing and help us with our supportive care agents. And then, especially with GPRC5D therapies, a nutritionist. And I find that getting them on board prior to the initiation of therapy is crucial. They can optimize our patient's nutritional status and talk them through a diet plan for patients so that we're not seeing weight loss and that we can manage some of these, again, on target off tumor side effects. On this slide, we see that a comparison with infection rates between GPRC5D versus BCMA targeting T cell therapies. So we see with GPRC5D, we see those less serious infections. And this is something that we can consider for patients if we're worried about serious infections. Patients have a history of serious infections. Um, targeting GPRC5D, we certainly do see infections in our patient population, but when we target GPRC5D, we don't see as many serious infections. And then with any T cell redirecting therapy, CRS, cytokine release syndrome, it should be anticipated. The majority of patients are going to have a CRS event. So we saw that approximately 77% of patients had CRS, but they're mainly mild. So a grade 1, grade 2. So patients often will present with a fever. And at our institution, we are pretty aggressive with the grade 1. We do provide the supportive care with acetaminophen, but we also initiate tocilizumab with a grade 1 CRS because we don't want the CRS to progress to a grade 2 and 3. And then with grade 2, you're always going to have the fever. The fever is consistent with when we grade. So you have to have a fever. But then as we go up in grade, we see the addition of hypotension plus or minus, right? Hypoxia. So depending on how we're managing the patient is going to dictate the grade of the CRS. So if patients need oxygen or vasopressors, that will dictate the grade and severity. We're going to hold our dosing as appropriate and according to your institutional guidelines is how we're going to manage patients. And I don't know if I said this enough, but there are these on-target off-tumor side effects that we see with GPRC5D. As Dr. Richter was saying, that GPRC5D heavily expressed on myeloma cells, but also expressed on keratinized cells. So think the oral cavity, so tongue, your skin, your nails. So dysgeusia, which it decrease in taste. Patients can have taste changes. They can have complete loss of taste. And we see the frequency up to 70%. But in my experience in the real world, all my patients have some degree of dysgeusia. And this, it's usually mild when we're grading it, but this can greatly affect a patient's quality of life. And so that's why I think education is key, that we anticipate these side effects prior to the initiation of therapy. We also do see nail disorder. So again, keratinized cells. Our nails, patients will report ridging, brittle nails, dry skin. We can also see rashes where we see peeling on the palms and the soles of the feet. We also see, again, the oral toxicities, dry mouth, which can lead to difficulty swallowing. So we want to keep our patients on therapy because we know that, GPRC5D targeting therapies are very efficacious. So I need to keep my patients on therapy by appropriately managing their side effects. So dysgeusia, as I said, even though we grade them as mild, really impacts a patient's quality of life. So that's where our nutritionist becomes very important to really counsel a patient through meal planning and adding in certain things like citrus and herbs to enhance flavors, making sure that patients are taking adequate protein so we're not losing weight. At our institution, we initiate dexamethasone and nystatin, swish and spits, and saliva substitutes for that dry mouth. So, again, and in addition with that nutrition is counseling through the patients. We advise patients to limit caffeine, especially if patients are having difficulty swallowing, to avoid certain foods. Most patients say that, meat such as chicken or steak can be difficult to swallow. So what foods to avoid if you're having, if patients are experiencing dysgeusia? And we really want to avoid the weight loss. So working with the nutritionist to get the protein and the calories in a patient's diet. With the skin toxicities, with the initiation of therapy, we advise patients to use heavy moisturizers, not take those scalding hot showers. And then if we do see skin breakdown, depending on the severity, we would hold treatment, use a steroid cream as indicated. And for nail toxicities, These are going to be for the duration of therapy. So while the patient is taking therapy, they will have those brittle nails. And so what we advise patients is to make sure their nails are cut short and clean. Use that vitamin E cuticle oil. Keep the cuticles. We don't want them to get infected. So if we do suspect infections, we'll use the antibiotic ointments. So, education is key to keeping patients on therapy. So, setting patients' expectations on with the initiation of therapy, and getting our support in. So, our other providers, such as nutritionists, social work, and making sure the patient has the information they need for and going to the forums like HealthTree.org, where they provide a lot of good patient information, reliable patient information. And we need to educate our patients on these adverse events. They're manageable, and we can keep patients on therapy so that they can really benefit from the GPRC5D targeting agents. Okay, so I'm going to bring Dr. Richter back in, and let's go back to our patient, Diane. So we discussed starting her with talquetamab. So Dr. Richter, how would you address monitoring and dosing considerations when starting her on therapy?
So I think one of the things that T cell redirection therapy has taught us, and this is BCMA and GPRC5D based bispecifics, is that when we encounter toxicities, one of the best ways to attack it is not necessarily to lower the dose, but to extend out the interval. And I think this is a departure from how we've classically managed side effects in myeloma. We all have patients on 25 milligrams of lenalidomide who have low blood counts. We hold the drug and then we dose reduce to 15 milligrams. Whereas what we've seen with drugs like talquetamab is that if you have a patient dosed at weekly or every other week and they're having toxicity, the big thing is not necessarily to drop the dose from 800 micrograms to kilo down to 400, but to extend out the dosing from weekly to every other week or from every other week out to monthly. And I think this has really been the best way, along with the supportive care measures that you've mentioned in great detail, to be able to keep people in remission and disease control on therapy.
Great point. And I think too that our patients do better when we manage, when we maybe spread out the dosing. Patients can tolerate taste more when there's less frequent dosing. And then just moving on. So we talked about the on target off tumor side effects, but then, we see the more common side effects that we anticipate. So the cytokine release syndrome. So we do mitigate this. So we evaluate for infection because we know that infection can mimic the signs and symptoms of cytokine release. Um, and then we want to, during this step up dosing, so we give small amounts of drug before we hit the full dose, and this is to mitigate the risk of CRS. So we do give pre-medications during that step up dose phase. So we'll do that 1 to 3 hours prior to the dosing. Um, and then after the dose, we're going to monitor patients frequently, and you're going to go by your institutional standards, but we monitor vital signs frequently. We monitor for signs and symptoms of cytokine release and neurotoxicity. Um, and then again, throughout this, we may start seeing those on target off tumor side effects during that step up dosing. So again, constant enforcement with the patient. And then with each visit, so we get that patient through the initial step up dosing, and then we need to constantly evaluate our patients for the on target off tumor side effects, the oral toxicities, the skin toxicities, and to discuss, as Dr. Richter was saying, do we need to hold the dose? Do we need to spread out the dosing? Um, And as I was saying, we mitigate with CRS through a step up dosing approach. So, um, and depending on how we want to, what treatment schedule we want to manage the patient with, either a weekly dosing or a biweekly dosing will dictate how we're going to step up the patient. So patients, again, will start on a very small dose and then slowly work their way up to the full dose to mitigate the CRS. And then we will continue patients on either a weekly schedule or a biweekly schedule. So for our patients in the community, we typically do that inpatient dosing for the step up, but more and more institutions are doing this as an outpatient. But for the community centers, we do this day in, day out. Dr. Richter and I, we're at a large academic center. For patients out into the community, we do collaborate with our community oncology centers where we will um, provide the patient with that step-up dosing, and then collaborate in returning the patient back to the community. So, Dr. Richter, why don't you tell us about Vicky?
Sure. So this is Vicky. And Vicky was initially diagnosed with an MGUS back in 2018. However, in 2021, she progressed and ultimately was diagnosed as having symptomatic multiple myeloma. She received frontline therapy with induction and consolidation with autologous stem cell transplantation. After subsequent relapse, Vicky cycled through several other different types of treatments. And one of the issues along the way was that she experienced multiple episodes of infections. However, in 2024, talquetamab was chosen as the next line of therapy to manage Vicky's myeloma. And one of the main reasons was that we recognized that when it comes to T cell redirection therapy, although we can see infections with GPRC5D based assets, it does appear to be lower than that of the BCMA targeted agents. So we ended up treating her with talquetamab, knowing that this still kept another arrow in our quiver that we can use BCMA-based therapy at a subsequent line. So ultimately, Vicky went on to receive therapy with talquetamab and is doing quite well. And subsequently, we were able to reach back out to Vicky to ask her about her thoughts about utilizing GPRC5D as an option for her line of treatment multiple myeloma. And overall, she was very appreciative of the fact that there were multiple options in front of her. And what was a big impact on her quality of life had been infections with things like RSV and pneumonia. And she was very much appreciative that the next line of therapy was associated with fewer infections overall. Now, she was a little bit apprehensive about this new line of therapy because of the different side effects that we prepped her for, including some of the nail skin changes as well as dysgeusia. However, she really dove into it. She went along with the supportive care program that we provided. And ultimately, she was even happier knowing in the back of her mind that should she suffer another relapse from her disease, this preserves the BCMA antigen for use in subsequent therapies, including not only another bispecific antibody, but also CAR T cell therapy. So after the step up period, Vicky ultimately went on to the bi-weekly schedule, 800 micrograms per kilo every 2 weeks. Um, and in general, this was the protocol that we followed. Bi-weekly weight checks to make sure that along the way, patients may not notice if they're eating less, but the scale never lies. We made sure to review all different concerns that the patient may have, even minor ones, to try to get ahead of them. Regular monitoring, including blood work at these biweekly visits, along with vital signs, blood pressure, temperature, and oxygen saturation. And again, making sure along the way to make sure that there's no evidence of delayed cytokine release syndrome or immune effector cell associated neurotoxicity syndrome. And at the time of this recording, Vicky remains in remission with no new safety signals that have been reported since starting treatment with talquetamab. I'd like to turn it back over to Donna for some closing thoughts on this program.
So, I think what we saw today is that GPRC5D targeting therapies can be very efficacious for patients. Majority of patients respond, and the durability of response. We see less infections, as we see in Vicky's case, where infections became very problematic for her. So offering her a therapy that we don't see the serious infections is important in our patient population. We do see those on-target, off-tumor side effects, but with proper supportive care measures, we can keep patients on therapy, and they can be very successful and have great outcomes. Thank you, Dr. Richter, for joining me today. Any last thoughts, Dr. Richter?
No, it's been a real pleasure working with you and with our medical colleagues out there about how to optimize outcomes with these new great agents.
And again, thank you for joining us today, and we hope you found this program helpful.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, the HealthTree Foundation for Multiple Myeloma. This activity is supported by an educational grant from Johnson & Johnson. To access all materials for this activity, visit peerview.com/WMD860.